Welcome to Leadership and Mental Health, how leaders need to take care of their teams. Thank you for joining us today. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be co-moderating the webinar today. This webinar is part of our Harnessing Talent Alliance series. Harnessing Talent, Alliance for Recruiting and Retaining Canadians with Disabilities, is a 3-year project funded by Employment and Social Development Canada. We would like to thank our 9 founding partner organizations, as well as our academic team. If you would like to learn more, please visit our website, harnessingtalentalliance.ca, and follow us through our Harnessing Talent social media channels. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. Today, we're very excited to welcome Dr. Kevin Kelloway and Dr. Alade. Dr. Alade is Director of the CN Center for Occupational Health and Safety and a professor in Industrial and Organizational Psychology at St. Mary's University in Halifax, Canada. Arla, thank you so much for co-moderating the webinar and Q&A session. Without further wait, I will let you introduce our guest speaker.
Thank you very much, Yusra. And I'm very pleased to co-moderate the webinar today and to introduce my esteemed colleague, Dr. Kevin Callaway. So Kevin is the Tier 1 Canada Research Chair in Occupational Health Psychology and Professor of Organizational Psychology at St. Mary's University in Halifax. His research has always focused on issues related to organizational leadership, to mental health in the workplace, and to occupational health psychology in general. And he has been a very prolific researcher. He has published over 200 articles and book chapters. He has edited and published 14 books dealing with all of these issues. He has also been recognized for these accomplishments. He's been an elected fellow of 4 academic societies. He has received awards for distinguished contributions to IO psychology and for being a distinguished psychologist in management. He's active in several professional associations and served as president of the Canadian Psychological Association in 2016. He is deemed a very popular public speaker, as you will be able to judge in a few moments, and he also runs a consultancy advising for both public and private sector clients on a variety of issues related to leadership and human resource management. So without further ado, I'm going to hand it over to Kevin.
Okay, thank you, Arla. Pleased to be here this afternoon to talk about one of my favorite topics, and that's how leadership in organizations affects employees' mental health. And I'm going to start with a little maybe overview of the field and where we've been and what's going on right now, and then talk more specifically about leadership, and in particular how leaders can engage in what I think are the 3 essential elements of a mental health program, and that's prevention, intervention, and accommodation. And I'll talk about each of those as we go on. So if you're old enough, you'll remember that after Watergate, every political scandal or every tempest in a teapot got tagged with the gate at the end of it. So after Watergate, everything was some kind of gate. And if you're east of Montreal, ever since that damn movie came out, we're all required now to make a reference to the perfect storm. And really, with mental health, there has been a perfect storm in Canada. A lot of things have come together at the same time to sort of generate not only interest, but activity in the field of mental health. So even 10, certainly 15 years ago, when I began 30 years ago, you really couldn't go into an organization and start talking about mental health because it wasn't on the agenda. Nobody wanted to listen to you. And it was hard enough to sell things like stress, that you'd have to go in and pitch that as you'd have to tie it to absenteeism or productivity or something more relevant to organizations, because they saw that whole area of stress and mental health as being really irrelevant to what they did. So a lot of things have changed. In Canada in particular, we had this growth in legislation focusing on workplace violence and aggression or harassment, I think every jurisdiction now has some legislation on the books in one of those areas, and most have gone with sort of this broad scope legislation that includes both violence and aggression and harassment, and that opens up the courts really to look at a broader range of psychosocial issues in the workplace. So things that were formerly, you know, sort of off the radar are now very much on the radar. We've had some workers' comp decisions that hold employers responsible for stress-related disorders. We have court decisions that point to the responsibilities of employers. Any organizations I've talked to, any of them, that they periodically do a drug plan review where they ask the provider to figure out where they're spending all their money in their drug plans. Almost invariably, those come back as the big two are you know, beta blockers and antidepressants. So we have heart problems and we're depressed, and that's where all the drug costs are going. Talk to insurers, they talk about the spiraling costs of long-term disability and short-term disability, primarily attributed to, in some broad sense, mental health claims. So claims can be for a mental health issue, people going off work because they're depressed or they have an anxiety disorder or whatever, or you can have mental health in some aspect contributing to other claims. So I'm off work because I've injured my back, but because I've injured my back, I can't go back to the type of work I did, and now because of that, I'm developing some depression. And insurers will point out very quickly that they say 30 to 40% of their claims may be stress related, but up to 70% of their costs, because stress claims, mental health claims, we don't have a good nomenclature for this right now. They're all medical claims, obviously, but to distinguish them from physical claims. But they tend to be longer than physical claims. So I always say if I fall off my chair and break my arm, someone will get me to an emergency room and they'll x-ray me and cast my arm, and I can be back to work, if not tomorrow, certainly within a couple of days. If I go to my physician and tell him that I'm depressed or I'm having feelings of anxiety, he'll gladly write me a note for 6 weeks off work or 6 months off work or whatever we think my benefit plan will pay for. So those claims tend to be very much longer than simply physical claims. Then, of course, we had the Mental Health Commission doing great work in promoting mental health at work. We have the Bell Let's Talk campaign, the promulgation of the Canadian Standard for Psychological Health and Safety in the Workplace in 2013. A bunch of activity around that, lots of organizations sending people off to mental health first aid courses, many organizations, particularly first responder organizations, investing heavily in the Roads to Mental Readiness program, a program developed in the military, but now adapted and applied widely across first responders, so firefighters, paramedics, police forces, and the like. Lots of things going on in all of those areas. So some companies trying to implement the standard or investing in these programs. And then as you think about that, there's some concerns that arise. There's lots of activity going on in this space and not a lot of evidence. So in fact, we adopt and roll out programs pretty much across the country without any good evidence that it works. If you look at the evidence on something like mental health first aid, that mental health first aid programs have been around, it seems like forever, and lots of good data on them, but no good evidence that simply raising awareness, which is the focus of mental health first aid, simply raising awareness of mental health issues actually does anything. So the theory was if we increase awareness, we will increase the rate at which people will access services and seek help, and they'll be more willing to seek help, but there's no good evidence that that actually works in that way. Now, I'll contradict myself later on because I think we have some evidence that some aspects of that work, but in general, just this more openness to talk about mental health issues in the workplace does not guarantee that people will get the help they need or seek the help they need. in organizations. So it's got to be, I'm starting to see articles now with titles like, beyond awareness, and now we've had awareness, now we need action. And I think that's very true, that we actually have to do something. And of course, there's a booming consulting industry around this. There's lots of people willing to help organizations access these programs or implement programs that are designed to increase awareness. Again, nothing the matter with increasing awareness, but it can't be the whole solution. And in fact, we know it isn't the whole solution. So we need to do more. In my work, I focus on particularly on leaders, and I think it's Jerry Pouzes that has this image that I really like of leaders being in the leadership spotlight. And I think this, think of going to a play or going to the theater and seeing someone standing in the spotlight. And I think there's two things that go on there. One is that everything that person does is magnified. And I think that's especially true for leaders in organizations. As employees, we listen to our leaders and we talk about our leaders and we repeat what they said because we're trying to figure out what's going on. So everything gets magnified when they're in that spotlight. It's not necessarily that the leaders know more or are more capable than anybody else. It's just that formal position they have in standing in that spotlight. Everything they do gets a little more magnified and has more effect. So in our work, we've been focusing intently on leaders and how they play into this aspect of increasing mental health in the workplace. And we're really interested in what leaders can actually do in a very pragmatic sense to improve workplace mental health. So we know, the literature on leadership is quite clear. It's been around for a long while. We know that good leaders, we often study transformational leaders, but just broadly effective leadership. We know that it works. There's good data that you can teach people to be better leaders, and when you do, their performance increases and other outcomes that you might be interested in increase. We know that ineffective leadership styles, leaders who are passive and don't do anything, or leaders who are abusive and harsh, have very detrimental effects on performance and safety outcomes and a whole range of outcomes. And just broadly, Brad Gilbreth, a researcher in the States, has the great quote that I stole from him. I use it all the time. He said, "The observation that how a leader treats you affects your mental health would come as no surprise to any working adult." We all know this. We know that leaders have an impact on our day-to-day well-being and how we're feeling. We know that leaders have a great effect on us. And I often say, when I explain to my family members who are not researchers and not in my area of work, that I study whether the way leaders treat you has an effect on you, they can't believe that we're wasting good tax money on this. So again, like Rodney Dangerfield, I get very little respect for the research I do. But we know that leaders have a great effect. We've known that particularly around bad leadership. I think the first study we've ever found on this is somewhere back in the early 1960s, looking at harsh leadership and its effect on people. But more recently, we also know that good leaders have a more positive effect as well. So leaders appear to be an avenue in which we can change the workplace. I think if you change leaders and how they treat people, you are really changing the workplace. So I want to talk about what leaders can do in 3 areas of mental health. I think there's 3 things we need to do in mental health programming. And this is why I say awareness is not enough. So first off, we need to focus on prevention. And prevention deals with trying to mitigate organizational stressors, trying to provide people with resources, trying to stop contributing to the burdens that people might already have. So there's things we can do that simply make workplaces a better place to be, and that's got to be our first responsibility, is to do that. But we have to go beyond that, because not all mental health problems originate in the workplace. And you can be depressed because you're poorly treated at work. You can be depressed because of something going on in your family. You can be depressed because you woke up this morning and you're depressed, and there's no really good rational reason for it. So for all those things, so we need to move beyond just prevention and also talk about intervention, how we can help people who might be experiencing a mental health crisis or a mental health problem, and how we can get them the resources and help they need. And then we need to talk about accommodation and we often talk about accommodation in terms of return to work after an injury, and certainly when someone's been off on long-term or short-term disability, then we might talk about what do they need, what kind of adjustments might they need to come back in the workplace, but even more importantly, what kind of accommodations might keep people in the workplace in the first place. So maybe this model of sending people away for 6 weeks, 6 months, whatever, is not the most effective thing we can do. So we start with prevention. Occupational health psychologists love prevention. It's the primary way we like to intervene, because it's always this notion of change the stressor. And we know about the effects of workplace stress. There's a huge literature on workplace stress. Has some problems, but there's lots of evidence that stress is bad for us in many, many contexts. So when we look at leaders, one of the, I always like to talk about Jennifer Wong's study because I think it's a classic example. And what Jennifer did for her master's thesis is a diary study. So we collect data on 55 nursing home employees, but we collected data every hour on the hour, from the time they woke up in the morning till the time they went to bed. So we had them all wear ambulatory blood pressure monitors from when they wake up until they went to bed. And every time the ambulatory blood pressure monitor is a blood pressure cuff that's linked to a battery pack and a hard drive that you wear on your belt. So you can wear them around and they will inflate. You can program them, we program them to inflate every hour. So they inflate, they take your blood pressure and record that stored on the hard drive. And every time that happened, we asked the people to fill out a very short questionnaire. They had a little diary booklet they carried around with them for the day of the study. And I should tell you, just in terms of safety, we told them, you know, if you're in the middle of lifting somebody, we asked them when the blood pressure cuff starts to inflate, try to stand still. But if you're in the middle of lifting somebody or doing something, there was actually a switch where they could just hit it and it would turn off and reset in 15 minutes. So nobody was dropping residents on the floor or something where they got their blood pressure taken. So in this diary study, there was a one-item measure, because very short measures, and all we could get people to do is rate. We asked them, did you talk to your supervisor in the last hour, i.e. since the last blood pressure meeting? And if you did, how was that on a scale from 1 to 10? 10's very good, 1's very bad. We end up, because we study 55 people, but we do it from the time they wake up till the time they go to bed, we end up with 422 data points. Two interesting things come out of this study, I think. One is we find the quality of the interaction with the supervisor is directly linked to systolic blood pressure. If you had a bad interaction with your supervisor, your blood pressure goes up on the next reading, right? So this is maybe not so surprising. This is what Hanselia taught us about the stress response and the general adaptation syndrome. You expose people to stressors, their blood pressure goes up. That's one of the aspects of the stress response. So we sort of expected that to happen. Nice to have it confirmed. Maybe a little surprising to people that supervisors are having that much effect, but certainly, you know, if you think of supervisors speaking harshly to you, disciplining you, or whatever, that can drive your blood pressure up. The second thing that happened that we didn't really expect is, and all these data are controlling for all kinds of things, whether you smoke, whether you had coffee, your physical size, whether you just ran upstairs, all those things. We have lots of control measures here. But the second thing that we found, aside from the sort of cardiac reactivity thing, that's blood, supervisor's harsh to you, your blood pressure comes up, we found if that happens enough times during the day, that when you go home at night, your blood pressure does not come back down. So if you had repeated harsh interactions with your supervisor or poor interactions, what happens after work is that your blood pressure stays up. Now, we only have a short-term 1-day study, but if that happens enough and your blood pressure is not coming back down, now we're calling that hypertension and we're putting you on medication, right? And there are some long-term studies linking exactly this type of behavior. The way a leader treats you is clearly linked to cardiovascular disease in the long term and the likelihood of you experiencing cardiovascular incidents. So I think we caught a little piece of that, where we find that if you have repeated bad interactions with your supervisor, it affects your blood pressure. Your blood pressure in the moment, but it also affects your blood pressure in a longer term. So when you go home at night, you're still kind of agitated and your blood pressure is still up. So that's one version. We looked at harsh leadership. We've also looked at passive leadership. So passive leaders are leaders who don't do anything. They don't make decisions. They don't help people. They don't answer questions. They're sort of there in the role, but they really don't do anything. And we have been playing around for a couple of years in my lab with a model that says if you have a passive leader, you're more likely to experience work-family conflict, because it's the passive leaders who don't plan ahead, who will drop work on your desk at 4 o'clock in the afternoon, and has to be in by tomorrow morning, or you end up working all weekend or something like that. So that's the first part, passive leadership, predicting work-family conflict. And then the second part of that was we thought work-family conflict would predict incivility, because we know if you put people under enough stress at work, one of the first things to go is your social skills. So you're not being polite to people, and you're snapping at people, and maybe you're yelling at people or speaking louder than you should, or maybe you're being rude to people. We know this is a very common response to stress. So we thought this, okay, if you have a bad leader, you're going to have more work-family conflict, more incivility in the workplace. And passive leaders, we think, sort of makes that worse because they don't intervene. So when you're being rude to somebody as a result of your stress, they're not stepping in and say, hey, take a breath, take a step back, calm yourself here, think about what you're saying. So we think that passive leaders actually contribute to that sort of incivility spiral. We've had 2 studies now we've looked at that, one with Taylor Oakey based on some cross-sectional survey that support exactly that model. So passive leadership is associated with work-family conflict, which leads to incivility, and then passive leaders make that link even worse. And then in the second study, some of my students and I looked at, we have sort of 4-month longitudinal data, but also shows the same effect. So that if you have passive leaders, more work-family conflict, more incivility. And in that study, we showed that transformational leadership, so more effective leadership, if you have leaders who are more effective, they can intervene and break those links. So you might still have people with work-family conflict who are being a little uncivil, but good leaders then step in and help people resolve that issue. So we have some decent data that suggests that both good leadership and bad leadership can have real effects on people. But there's a problem in this, and much of the stress literature, that most of the stress research, is we really don't have a lot of intervention studies. So we can, I can write you a whole book on, and I think I have, but I can write you a whole book on the causes of stress and what stress looks like, and then you say, well, what do we do to fix that? And that's a little more iffy because we don't have good interventions. And the interventions that we do have are all about sort of changing the person. So we don't really reduce your stress, we teach you mindfulness or resilience or stress management. Again, nothing the matter with any of these programs. They can work for people, and when they do, that's great, but it doesn't change the situation. If you're in a stressful environment and we teach you to be resilient, then you just get to spend more time in that same stressful environment. So the idea of primary intervention is actually change that environment. And there aren't very many studies that look at that. Many more that look at these individual, can you change the individual? Not many that look at, can you change the environment? So as I said, when we try to teach leaders to become better at what they do, I think we're changing the environment for employees because we're changing the quality of leadership. That's what Margaret McKee and Kathy Driscoll and Elizabeth Kelly and I looked at in a study where we got to train I think in total it was 165 leaders. It was every leader in an organization, from the CEO down to the first line supervisors. The organization was very good to us in terms of research. They allowed us to use a waitlist control group design, so we randomly assign people to training in control groups. We can do a really nice experiment. The training was a 1.5 days of transformational leadership training, fairly a standard approach that we use in a lot of our executive development and things, and we just taught people about what being an effective leader really means. And then they met with coaches and they reviewed feedback from their employees, and so all very tied to previous work we'd done on how to develop transformational leaders. So it's an approach that we were pretty confident would work. And what we wanted to see is, if we teach leaders to become better at being leaders, will that affect employee well-being? And that's essentially what we found. So if we teach people to become better leaders, first off, employees notice that difference. So we compare pre-test and post-test. Employees can tell us, oh, this lead, and the employees don't know whether the leader had been to training or not, but they could tell us, this leader is better at what they do now. They're more inspiring, or they're more motivational, they're more attuned to me, whatever it is, they're more transformational. Second point is, when they saw that change in leadership, we used to measure workplace spirituality, but it really focused on meaning at work and the meaning people ascribe to their job. So when they saw leaders as performing better, they also said, these same leaders, created the sense of meaning for me. So I see the purpose of my job, I see the purpose of my task, and then that sense of meaning also predicted well-being. So it made a difference to the individuals. And just serendipitously, we realized after the study that the way we'd collect the data, we'd end up with pre-test and post-test data on the leaders' well-being, even though that wasn't our primary interest. But I'm a statistician by nature, so if I have data, I'm going to analyze it. And one of the things we find is that leaders who we in the train group, the people we taught to be better leaders, their mental health improved as well from pre-test to post-test. And this makes sense because in this organization, as in many organizations, you get to be a leader just by being good at something else. A good nurse becomes a nurse manager, a good accountant becomes a managing partner, etc. It doesn't mean you're ever taught anything about how to lead or what you should be doing. In this study, we showed that if we can teach people to become more effective leaders, it improves employee well-being. It also improves the leader's well-being. So moving on, we've been working on that for a while now, and then we started to look at this notion of the psychologically healthy workplace, and there are all kinds of definitions of what that is. I think they're all sort of equally good or equally bad, if you will. People just sort of chose factors that would define the psychologically healthy workplace. So the Canadian Standard, they chose 13 factors. The American Psychological Association has a model that chose 5 factors, and that was one we were more familiar with at the time. So we started working with that model and said, well, how can leaders actually create the conditions that APA tells us result in a psychologically healthy workplace? And what we came up with, we've been referring to as the right leadership model. Sam Penny and Jen Dimmoff and I wrote a chapter on this, and we've been really focusing on 5 things that APA says constitutes a healthy workplace, but also that we know are behavioral, and we can teach people exactly what to do. So the R in right stands for recognition, right? And recognition is just that telling people that they've done a good job. When we do leadership training in the right model, what we encourage leaders to do is to set a goal for themselves, tell 3 people a day you've done a good job. And we sort of dress that up. You're saying you can't be very vague about this or very general. You have to be very specific. You have to be able to say, I saw the way you did this. I saw the way you dealt with that customer. I saw the way you handled this situation. That was great. Thank you. So we're not emphasizing rewards or anything like that. We're just saying, tell people when they've done a good job. We tell leaders to promote involvement of other people, to start asking questions. In transformational leadership theory, this is known as intellectual stimulation, but really asking people, what do you think we should do? What do you think we should do about this? How can we make this better? You know, to get the involvement of everybody in the decisions that are going on in the workplace. We talk about growth and development, so leaders should focus on employee growth and development, finding out from people where they want to go with their career and saying, what can I get you? What can I get you? What can I do for you? You know, how can I help you get where you want to go? We talk about the importance of leaders being involved in health and safety. Have done a ton of work on safety leadership over the years, and if there's one clear finding, it's that if leaders don't care about safety, nobody cares about safety. And the simplest way to change that is to get leaders talking about safety, and I mean safety in a broader context, so all aspects of well-being, so not just physical accidents, but including stress and including work-family issues and including that whole range of things that our employees experience. And then we talk about the importance of teamwork. We stuck that in. That's not part of APA's model, but we know that work in modern organizations is increasingly done in groups and in teams. And we say, well, leaders have to spend some time on improving the efficacy of teamwork. So on team development, we stress the notion of debriefing after a work project or after something is completed. We talk about the importance of doing huddles, you know, brief team meetings just to review where we are and what we're doing here. Anything we can do to keep the focus on the team and working together as a team. So we've been talking to leaders about doing these 5 sorts of things, trying to stress 5 very behavioral things that you can do. So not abstract, go out and be inspiring. Who knows how to do that? But here, something very specific. Tell 3 people today that they've done a good job. And that's starting to come out. We know we have a measure of right leadership that we know correlates strongly with transformational leadership. We found in our research that subordinate ratings of right leadership are associated with an increased sense of psychological safety at work. So team members feel safer to make mistakes and to offer opinions. We know that when leaders engage in the right behaviors, employees report more engagement. We use a measure called Love of the Job that Michelle Innes and Nick Turner and Julian Browling and Lori Francis and I and Connie Bygrave, and there's a whole bunch of authors on this, developed. But we know that when leaders behave in the right ways, employees report increased engagement, and we know that results in increased psychological well-being for employees as well. We've done some initial interventions. We don't have good control groups and very rigorous designs here, but we're fairly confident we can teach the right style. We have a half-day workshop that we've run in several organizations now that seems to work. We know that employee engagement and well-being both increase as a result of that training. We're just running a pilot test now. In fact, right today, I think we just started collecting our time to data. So I'm anxious to see how that came out. We've been working with the government department to test out this model of leadership. And of course, I have to make my pitch. We're always looking for research collaboration partners, organizations interested in participating in training to further evaluate that. But there's at least some things that we've shown leaders can do to, if not prevent stress, at least buffer it in some ways to help employees deal with the workplace by focusing on those 5 behaviors: recognition, involvement, growth and development, health and safety, and teamwork. So leaders have a role to play in that element of prevention. The way we as leaders treat our employees has a direct effect on their well-being. I want to move now and talk briefly about intervention because, as I said, not all mental health issues originate in the workplace. but they do manifest in the workplace. So as I said, I may be depressed for a whole variety of reasons. I may have anxiety for a whole variety of reasons. Some of them are work-related, some of them are not, but they're going to show up in the workplace because I bring them to work, right? And when I'm at work, people who know me well that I work with every day will see changes in my behavior. So we started a line of research. This was largely led by Jennifer Dimmoff, who's now at the University of Ottawa. And what we were working on is the notion that leaders could be intervention agents. So that it not just that we certainly want leaders to be better leaders and promote a psychologically healthy workplace, but we want them to be able to recognize when people are struggling and to be able to step in and not be counselors, but to offer people and direct people to the resources that their organization makes available. So we start off with a very qualitative study where we interviewed managers. This comes out of, in executive programs, I often ask how many people in the program had managed people who had known to have mental health issues. And by that, I mean, you know their diagnosis, you know there's a request for accommodation or whatever. And very commonly, we find 70, 80% of the class has dealt with that, although they all tell us no one has had any training or experience in it. So we interviewed managers that we knew had some experience in dealing with employees who had mental health issues, asking about that experience. And one of the things we wanted to focus on is, how do managers know? How do they recognize, or what do they experience from employees? What are the behavioral signs that somebody might be struggling or in crisis? And what managers told us about was these four things. They talked about emotional outbursts. They said people would be crying at work or yelling at work or something like that. They talked about social withdrawal. So this is not being absent from work, that's the next one. This is social withdrawal. So people who always went to coffee or always went to lunch with the gang now don't go anymore. And I always point out that just because of where I work, just because you don't go to coffee with a bunch of people doesn't mean you have a problem. It might mean you're a faculty member, because we're all introverts and we sit in our office and that's the way we like it. But when that's a change in behavior, when you're used to always, go out after work with people, or you used to go to coffee, you used to go to lunch, and now suddenly you're not doing that, that's often symptomatic of a problem. They talked about absence. Interestingly, they told us when people start, we always talk about stress and absenteeism, but that's a very weak link empirically. And what really seems to happen is when people start missing a lot of time because they're having some kind of crisis or mental health issue, that's often the thing just before them going off on leave. So because we have absence control programs in organizations, most people don't want to phone in sick. They don't want to draw attention to themselves. So they try to keep attending. Presenteeism might be more of an issue really than absenteeism. And when they start missing work, that's often sort of a final stage before they really need some more serious intervention. And finally, managers told us about performance decrements, that people who were, they used to always be on time and now they're always late for things. They used to turn in high quality work and now that's starting to suffer, things like that. So managers were telling us there are behavioral indicators that they could find. Because all our measures of stress and all of our measures of depression and things like that, they're all self-report. So how does a manager know when to intervene? And that was our first issue. We used that information to develop a tool we call the Signs of Struggle Scale, the SOS. And it's really meant to be a third-party tool that leaders could use, not to rate or evaluate people, but to recognize when people are in crisis. And although we design it, our focus was on sort of mental health issues and mental health crises. It's really, when I think about it, that the behavioral signs of any kind of struggle. So it could be a person having a family issue, a victim of family violence, anything going on in their life, that they all, manifest in sort of the same way, so people can tell when somebody is struggling. And we focus on this notion of work impairment that emphasizes that you're just struggling to just get through the day-to-day stuff. And because of that, you're having difficulties. I won't bore you with all the psychometrics here, but the resulting scale did identify those 4 dimensions managers told us about, but some of them split out in different ways. So we end up with 5 dimensions. So we find that when managers are recognizing someone who's struggling, it's first off through emotional displays. So people, again, crying at work or yelling at others at work, or talking about being really sad, or I'm going to quit this place, or whatever. Again, social withdrawal, not going to coffee with people, not going to lunch with people when formerly you did. The new dimension that came out of the scale development was people engaging in we called it extreme behaviors. And that's a variety of things that are way out of the norm for people. So probably the most common, it's come up, I think, every time I've talked to managers about this, is just lack of personal hygiene. People stop taking care of themselves. Now, that's a classic symptom of someone in crisis, and often we treat it as a discipline problem rather than a mental health issue. There are some other issues, stealing, sabotage, destructive behavior in the workplace, threatening other people, things like that. So very extreme sorts of behaviors that all indicate someone's struggling. And then attendance issues, as I said, people start missing work, and performance issues. Right, so we end up with 5 different things that we think managers can use to identify people who are struggling. There are behavioral signs that give you, as a manager, the license to say, I can see you're struggling. You're not behaving the way you used to, and I don't need to know what it is, but is there some kind of help that you can use? Did you know we had an EAP program? Did you know we had a short-term leave program? We found out in that research, we actually had managers rate people, and then people report on their own stress. Those 2 things correlate at an astounding 0.7, which they probably should, because these are fairly extreme behaviors, so they're a very clear sign that somebody is struggling. We're working now on a whole bunch of projects using shorter forms of the SOS. It's a long scale. We think it probably has some utility as an app or a checklist. And again, managers tell us they're never quite sure when to talk to somebody, when to have that discussion about, are you struggling? Did you know we have these resources? And we see the SOS as one way of facilitating that. The managers could sit down and do a little rating themselves and say, oh yeah, maybe I should talk to them. We also had a line of research. This is where the SOS comes from. We were doing mental health awareness training. It's based on that mental health first aid model, where we teach managers to recognize the problem. So we teach them, the common signs of depression and burnout and anxiety and things like that. We help them provide assistance, not in the sense of being a counselor, but prior to any training we do an audit of the organization, and we make sure managers know what resources are available. Right? So you should have on hand, if you're a manager, the EAP number. You should know what the policies are. You should know who to call in HR, things like that, and then be able to get people to those resources or those other sources of help. We designed this as 3-hour training for managers. Jen always says the training has 2 sections. What do we know and where do you go? So what do you know is mental health literacy, and where do you go is what are the resources we have in the organization. Our focus has always been on detection, just recognizing when people are struggling or having a problem, not diagnosis, not treatment, not counseling. All you have to be able to say as a manager is, look, I can see you're struggling. It's having this effect in the workplace. Did you know we have these resources? These are things you might want to consider. You don't have to make any elaborate diagnosis or whatever. You just need to pass people on and make sure they know that the help is there for them. We did 2 studies evaluating that, 2 different organizations. They both follow the same pattern. So first we surveyed leaders about their knowledge. We trained one group, didn't train the other, and then 24 hours later we gave them another survey, sort of a test on what they learned, and then 8 weeks later we gave another test. What we found is when you train leaders, their knowledge on mental health issues goes up. The trained leaders are the red lines in these graphs, and the blue lines are the control group. We find their attitudes improve, so less stigma. It's sort of a reverse coded thing. We found their managers' sense of self-efficacy, their sense that they know how to deal with mental health issues in the workplace went up as a result of the training, and their intent to promote mental health issues in the workplace and their intent to use those tools also went up. So the pattern was the same in both organizations. In one of the organizations, we were able to access mental health claims. So we don't have a clear nice experimental design here, but we have quarterly data for the company we studied. Our intervention was in Q4 there, you can see in the box. And what you see generally in the graph is this company identified mental health claims. They referred to them as psychiatric claims because they came with a diagnosis. You had to have a diagnosis to get the leave provisions. So what you see is there's absolutely no change in the frequency of claims, right? There's nothing we taught or nothing we did that changes the incidence of mental health in the workplace. And I think that would be a lofty goal for any kind of training. I don't know of anything that would do that or have that dramatic effect. So no real change in frequency. The dramatic change was in duration. Claims reduced by an average of, see if I get my numbers right, I think it's 18 days per claim, which was like a 27% reduction in duration of claims. So people were coming back to work earlier. And I think that's for two reasons. One is we did talk in the training a little bit of accommodation and how to facilitate people returning to work. And the other is we got managers to intervene before somebody had a crisis in the workplace. Right? So if you're having one of the worst days of your life and you end up standing in the middle of your workplace screaming at your boss, and then you end up going back off on leave, it is very difficult to come back. Right? It is very difficult coming back because you feel embarrassed and what do people think of you and how can I work with that boss again? And if we can intervene before somebody reaches that breaking point and get them to the help they need before then, and if that means going off on leave, then that's what it means. But if we can help people that way, then it's easier for them to come back to work quicker. And more recently, we did that exact same study in 2 small organizations. In this case, we got data from both leaders and their subordinates, and we found that when we trained leaders, their subordinates report being more willing to seek help, more willing to use resources, and more willing to talk to supervisors about mental health issues. So employees, when we train leaders in how to intervene, employees see a difference and they're more willing to use those resources. I've left accommodation to last because it's the one I think we know the least about. There's some really great work going on in the UK right now. Rachel Lewis and Joanne Yarker are doing a lot on accommodating individuals for mental health issues. What we know right now is largely based on sort of the literature on accommodating physical problems in the workplace, and we know the range of things that people might need. They might need to either stay at work or to come back to work. They might need a change in their duties, maybe a short-term change. Maybe they can't do the things that they used to do. They might need some expanded timelines where maybe they can't meet the normal deadlines or the deadlines that they used to meet. They might need some restructured work. They might need just some more control over their work or their work time. So we know that those kinds of accommodations can help people come back to work earlier. We also know that they can help people stay at work. so they're not going off into the sort of abyss of long-term leave, where the longer you're away, the harder it is to come back. We know that if you do take leave, coming back is usually built on things like maintaining continued contact at the workplace. So again, the longer you're off, the more distant you become from the workplace. A supervisor can intervene very effectively here by phoning people, not to say, when are you coming back, but just phoning to say, just checking in, want to know if you're doing okay, anything you need from us, or maybe, we're all going to dinner next Friday if you want to join us, those sorts of things, so that people still maintain that contact. People coming back off leave need a plan to return. They need a story. Someone's going to ask you, where were you for the last 6 weeks? If the individual wants to say, look, I had a problem with depression or anxiety and I had to take some time off, that's perfectly fine. Look, that's their story. If they don't want to say that, they're still going to be asked. So they should, we tell leaders, tell your employees, I don't care what story you tell, but have a story, because someone's going to ask you. And you don't want to be caught sort of flat-footed. If you've been away a while and you come back, someone's going to ask where you were. So you can say you had surgery, you can say you had a mental health issue, you say whatever you want and you're comfortable saying with, but make sure you have that story, because somebody is going to ask you. There's a great review on return to work after injury by these authors, McEachran, Clark, Franchon, and Irwin, and they have this great line that I think sums up everything you need to know about return to work. They say, goodwill and trust are overarching conditions that are central to successful return to work arrangements. All of these things, just work accommodations, more control, expanded timelines, things like that, all of these work only if they're done with goodwill. So if the notion of even continued contact, if people have the impression that the supervisor's phoning to check up on me, it stops working. If people have the impression that they're phoning because this is someone who cares about me, cares about my well-being, then it can be an effective link back to the workplace. So that's what I have to say. Leadership involves three things when it comes to mental health in the workplace. It involves being actively involved in prevention and trying to be a better leader so you're not contributing to the problems. It requires some skills in intervention, so you know what resources the organization makes available to people and you're able to offer them to people, because everybody thinks, well, we all have the same benefits, we know what they are, but in actuality, people rarely know what benefits they have. And sometimes all it needs is for you as the leader to point that out. And then for a leader to be actively involved in accommodating people, making sure the work is structured in a way that helps them stay in the workplace or return to the workplace. That's my story and I'm sticking to it. So thank you very much for those of you who hung on to the end.
Thank you very much, Kevin. That was very interesting, as always. And during the time while you were talking, we were gathering a lot of questions coming in. And yes, you hung on to those individuals, and it looks like we actually gathered people as we went through. So that's great. And for people who are wanting to ask questions, there's still times just send in your questions as we're going through these, and if we can't get to them right now, we will be writing them up and getting answers back for you. So the first question, I think, Kevin, is a fairly straightforward one. When you first started talking about leadership, and you started talking about transformational leadership, one of the questions that came in is in terms of sort of what styles of leadership are considered to be transformational, or in another word, maybe what behaviors would you consider aspects to be transformational?
Sure, yeah, it's a very academic term, I know. Transformational leadership is the single most researched, single most well-validated theory of leadership that we have. And at risk of doing it a gross injustice, there are four things we talk about as sort of transformational behaviors. So we talk about inspirational motivation, raising people's expectations, and being inspiring and motivating people. We talk about idealized influence, which is like being a role model, being very clear about your values and acting with integrity. We talk about intellectual stimulation, which is sort of getting people to think and asking questions. And then we talk about individualized consideration, which I always say is just treating people like people, but being a mentor, being a coach, being an advisor, a helpmate. So transformational leadership is sort of those four things combined.
Excellent. Okay, thank you, Kevin. And then another question pertained to the way your study that you were talking about, the way that the leader treats you affects your cardiovascular health, and that other studies have been able to demonstrate this effect. So the question was, are there any other health problems that came up in those studies that were caused by leadership and or management issues?
Yeah, so the big two are cardiovascular and then psychological issues, so stress, depression, anxiety, things like that. There may well be others, so I don't want to say there's nothing else, but I know those have been the main focus. And it's linked to this model of stress, that those are the two most likely outcomes. But there's a whole range of conditions that are plausibly linked to stress. Either stress causes it or stress makes it worse. And you would expect that if you have a poor leader, for example, that's a stressful situation, and then you would experience these things. So just off the top of my head, stomach upsets, ulcers, asthma, things like that could all plausibly be linked to leadership issues. But in terms of the research, it's very much focused on cardiovascular and then psychological.
Thank you. And then another question has come up regarding to an actual practical recommendation. So what resources do you recommend to help convince leaders to give the go-ahead to commit to this issue?
Oh, wow. So that's the $100,000 question, is how do you get companies to get involved in this and get involved in a meaningful way? And I know when they first launched the standard, I was involved with the research group for the case study project. For people who know what that is, the Mental Health Commission was evaluating the implementation of the standard. And the thinking then was that, you had to make a business case and you had to show that this made sense. But frankly, the impression I have from talking to many organizations is that often leaders become committed through their own experience or they have their own story or somebody they know that brings their attention to this issue and they decide to do it. And it doesn't really seem to be so much this rational, somebody sitting down figuring out the costs and benefits. So how do you get people to that place? I don't know. We're still working on that.
Mm-hmm. Now, and following from some of your comment, you talked about you do research collaboration with organizations. So what would a research collaboration look like?
So it could look like a variety of things, but you notice in many of our studies, we go into organizations and do training or we collect data, one form or the other, and Arla will well know this. This is the ongoing struggle for those of us who do work in this area, is getting into organizations and being able to get the sort of data we need and hopefully provide some value back to the organization. So I think I mentioned that with the right leadership and things like that. And we're looking to do more training studies in organizations where we're happy to come in and do the training as long as we can get some evaluative data out of it.
Thank you. I think we have one quick more before maybe Yusra is going to cut me off. And it's pertaining to the Wong and Callaway study. Yeah. So, and when you're talking about that study and that so there was the possibility, or you're talking about the interaction with the leader. So if they had a negative interaction or they had a harsh interaction, I think was the word that came up here. Yeah. So maybe, is there a possibility that it maybe wasn't harsh, but just not helpful? So the example given here is an employee may have needed a stressful matter resolved. Interaction with the leader did not yield a resolution. So that this could be sort of 10 on a 10-point scale for stressful interaction. Yeah. But it's not necessarily so negative, but not necessarily harsh, but still ineffective, maybe management.
Yeah, that's a really good point. And so all we had, because we could only ask one question in the context of that study. So we just have this global rating, and we don't know whether it's a harsh or whether it was just ineffective or not helpful or what it is. We do know sort of anecdotally, now I don't have good data on this, we know that when people have a sort of ineffective interaction, or you asked a manager a question but they didn't really help you, that tends to generate a more middle rating than an extreme rating. And usually when they're using the extremes of the scale, they're really upset. But again, that's anecdotal, and there's certainly lots of work there to tease out, what types of interactions have those effects.
Excellent.
Yeah.
Thank you.
Thank you so much, both of you, for this webinar. So thank you, Kevin, for showing the correlation between mental health issues and leadership, as well as the role of leaders in prevention, intervention, and accommodation to support their teams. And Arla, thank you for making the time to moderate this compelling webinar and being so efficiently involved in the Harnessing Talent Alliance project. Thank you for being here.
My pleasure. Yep.
Yeah. So thank you for contributing to make the workplace a healthy, safe, and inclusive environment. And to all who are listening,